Hello everyone. Today we are going to discuss about hypertensive disorders in pregnancy. So what we will discuss is first we will discuss demographics. Then briefly we will discuss hemodynamics in pregnancy. Then definitions and disease phenotypes, how to diagnose the disease, which drugs to give in this condition, how to initiate the therapy, and which are the trials done in this disease, and take-home message. In demographics, incidence of hypertensive disorders in pregnancy, it varies between 5 to 15%, and prevalence is 7.8%. And preeclampsia, it accounts for 5.4% of the study population, and it has positive association with nulliparity, multi-fetal gestation, high maternal age, obesity, and chronic hypertension. Some hemodynamic alterations in pregnancy. So this alteration, they start as early as 6th week of gestation, and there will be increase in the plasma volume, and also there will be decrease in the systemic vascular resistance. So there will be fall in blood pressure by 5 to 10 millimeter of mercury. Also, it recovers to normal by the 3rd trimester, and there will be increase in the heart rate by approximately 10 beats per minute, and there will be increase in the stroke volume. Cardiac output will increase by 30 to 50%, and this all changes will be restored to normal between 2 weeks up to 6 months postpartum. So hypertensive disorders in pregnancy can be divided into 4 types primarily. One is gestational hypertension, second is preeclampsia and eclampsia, third is chronic hypertension, and fourth is chronic hypertension with superimposed preeclampsia. And there are special situations where preeclampsia with severe features, and another is HELLP syndrome, HELLP syndrome. First is gestational hypertension. So to diagnose a patient with gestational hypertension, patient should be previously normotensive, and there should be elevated blood pressure after 20th weeks of gestation. So systolic blood pressure of more than or equal to 140 millimeter of mercury, and diastolic blood pressure of more than or equal to 90 millimeter of mercury in 2 measurements which are taken 4 hours apart, or when the systolic blood pressure is more than or equal to 160 millimeter of mercury, and or diastolic blood pressure of more than or equal to 110 millimeter of mercury in 2 measurements which are taken close to each other. And there shouldn't be any evidence of proteinuria or preeclampsia related end organ dysfunction like elevated transaminases or thrombocytopenia, acute kidney injury, pulmonary edema, cerebral or visual symptoms. So in the absence of this proteinuria and preeclampsia related end organ dysfunction, we can diagnose gestational hypertension. Then comes preeclampsia and eclampsia. So, preeclampsia is defined as gestational hypertension with presence of proteinuria. Proteinuria is more than 0.3 grams per 24 hours of proteinuria, or urinary protein to creatinine ratio should be more than 0.3, or if we are doing urine dipstick test, then it should be 2+ on urine dipstick test to diagnose as proteinuria. And to diagnose new onset end organ damage, there should be thrombocytopenia of platelet less than 1 lakhs per deciliter, and renal insufficiency, creatinine of more than 1.1 milligram per deciliter, or doubling of the creatinine from the baseline. Or there should be increase in liver enzymes of more than twice the normal range, or absence of pulmonary edema, or new onset cerebral symptoms like characterized by headache or visual disturbances which are not relieved by analgesics. So these are the criteria which are needed to diagnose preeclampsia, and when there is preeclampsia and presence of seizures, it is called eclampsia. Pathophysiology of preeclampsia is like in first and second trimester, due to genetic factors or environmental factors or some immunological factors, there is abnormal placentation. And this abnormal placentation leads to abnormal placental perfusion. Abnormal means there is reduced placental perfusion, and this reduced placental perfusion will lead to hormonal imbalance, and there will be disturbance in the growth factors, and these growth factors will lead to systemic vascular endothelial dysfunction. There will be vasospasm, capillary vasospasm, and capillary leakage. Ultimately, this due to the systemic vascular endothelial dysfunction, then capillary vasospasm, and due to capillary leakage, there will be proteinuria and glomerular endotheliosis. There will be hypertension, and also there will be coagulation abnormalities and cerebral edema. There are severe features of preeclampsia. To diagnose preeclampsia with severe features, these features should be present to tell it as severe features. Like severe hypertension is characterized by systolic blood pressure of more than or equal to 160 millimeter of mercury, and or diastolic blood pressure of more than or equal to 110 millimeter of mercury. It should be present on at least 2 separate reading, and it should be taken at least 4 hours apart. Platelets count less than 1 lakh per deciliter. Pulmonary presence of pulmonary edema. Visual disturbances. New onset of headache, which is not relieved by taking analgesics. Renal dysfunction characterized by creatinine of more than 1.1 milligram per deciliter, or doubling of the creatinine from the baseline. There is increase in transaminases by more than twice the upper limit, and also persistent right upper quadrant pain. And HELLP syndrome, which is characterized by hemolysis, elevated liver enzymes, and low platelets. HELLP syndrome, HELLP syndrome, is distinct from preeclampsia. Like 15 to 20% of the patients with HELLP, they are found not to have preeclampsia. And the pathogenesis is attributed to complement activation, and it is complement-mediated thrombotic microangiopathy. There are several classifications to diagnose HELLP syndrome. One of this is Tenny's classification, in which all criteria are required to establish a diagnosis. One, to diagnose hemolysis, more than 2 of the following criteria should be present, like on peripheral smear examination, there should be presence of schistocytes or Burr cells, like haptoglobin should be less than 25 milligram per deciliter. There should be presence of severe anemia, and total bilirubin should be more than 1.2 milligram per deciliter. There should be elevated liver enzyme by more than twice the upper normal limit, and the presence of thrombocytopenia is less than 1 lakhs per deciliter. And here we should note that LDH is not a part of criteria. While there is another classification, Mississippi classification, where LDH is required for the classification. LDH more than 600 international unit is required for the classification. There are class 1, 2 and 3. Class 1 is the severest form of the HELLP syndrome, which is characterized by platelets of less than 50,000 per cubic millimeter, and AST or ALT of more than 70 international unit per liter. In class 2, platelets are between 50,000 to 1 lakhs per deciliter, and SGPT or SGOT of more than 70 international unit per liter. In class 3, platelets may be more than 1 lakh per cubic millimeter, and SGPT or SGOT will be more than 40 international unit per liter. So class 3 is the mildest form of HELLP syndrome, while class 1 is the severest form of HELLP syndrome as per Mississippi classification. There is also American College of Gynecology classification, which requires all of the following criteria. One is LDH level should be more than or equal to 600 international unit per liter. AST and ALT elevated more than twice the upper normal limit, and there should be less than 1 lakhs per microliter this platelet counts. Then comes chronic hypertension. So when we diagnose hypertension, which presents before 20 weeks of gestation, it is chronic hypertension, or it presents after 20 weeks of gestation, but it persists in the postpartum period. It is also called chronic hypertension. And chronic hypertensive patients, they usually don't have proteinuria unless they have chronic kidney disease, and therefore new onset of proteinuria, it suggests the development of superimposed preeclampsia in these cases. And even we can differentiate with serum urate level also. So if we want to distinguish between chronic hypertension and superimposed preeclampsia, in chronic hypertension there won't be urate elevation, while in superimposed preeclampsia we will find urate levels often elevated. When preeclampsia occurs in women who are known to have pre-existing hypertension, like when the hypertension was even present before the 20th week of gestation, it is called as chronic hypertension with superimposed preeclampsia. So means chronic hypertension plus all the findings of preeclampsia, that means chronic hypertension with superimposed preeclampsia. And it is associated with increased progression to preeclampsia, also associated with increased progression to HELLP syndrome and eclampsia. So there will be increased risk of prematurity and low birth weight, small for gestational age, and other postnatal complications like prolonged NICU stay and increased overall prenatal mortality in these cases. So if we want to compare these all conditions like preeclampsia, HELLP, and gestational hypertension, chronic hypertension, and chronic hypertension with superimposed preeclampsia, we can compare it and we can differentiate them. Like in preeclampsia, patient will be having normal blood pressure before pregnancy, and there will be presence of hypertension during pregnancy. There will be presence of proteinuria in preeclampsia, and other features like thrombocytopenia and increased transaminases will be variable. While in HELLP syndrome, it is mandatory that patient will be normotensive before pregnancy, and hypertension during pregnancy will be present in 82 to 88% of the cases. Proteinuria is usually present in HELLP syndrome, and other features like increased transaminases and thrombocytopenia, they are present in 100% of the cases. While in gestational hypertension, it is mandatory that patient is normotensive before pregnancy, and hypertension is detected after 20th week of the pregnancy. There will be no proteinuria, and there will be no thrombocytopenia, and there will be no evidence of increased transaminases. While in chronic hypertension, patient will not be normotensive before pregnancy. Patient will be hypertensive before pregnancy, and they will be having hypertension during pregnancy as well. The incidence of the proteinuria is variable, and there will be no thrombocytopenia and increased transaminases in chronic hypertension. And in chronic hypertension with superimposed preeclampsia, patient will not be normotensive before pregnancy. There will be hypertension during pregnancy, and there will be presence of proteinuria to diagnose superimposed preeclampsia. And the features like thrombocytopenia and increased transaminases, they will be variable. A diagnostic approach is to diagnose these four conditions. First of all, we need to confirm that whether the patient was hypertensive before 20th week of gestation or not. So if the patient was hypertensive before 20th week of gestation or after 6 weeks postpartum, then it is chronic hypertension. And if with chronic hypertension, there are features of preeclampsia, which develops during the pregnancy, then it is called as a chronic hypertension with superimposed preeclampsia. So if the patient was diagnosed only after the 20th week of gestation, diagnosed hypertensive only after 20th week of gestation, it can be either gestational hypertension or preeclampsia. But if the features of proteinuria are present, then it is preeclampsia. And if the features of proteinuria are not present, then it is gestational hypertension only. But if there are some features of severe preeclampsia present without even preeclampsia, we should suspect preeclampsia. Without even proteinuria, we should suspect preeclampsia. How to measure blood pressure in these cases? This is very important measurement of the blood pressure because we are going to treat those cases. So to confirm hypertension, it is very important to take blood pressure correctly. Patient should abstain from nicotine and or caffeine at least 1 hour prior to measurement, and patient should take rest for at least 5 minutes prior to taking blood pressure. Patient should be in sitting position or semi-reclining position, and there should be support at the back, and arm should be at the level of the heart. We should use appropriate sized cuff, and calibrated devices should be used, and we should repeat the measurement at varying time intervals to diagnose hypertension. And the home readings or ambulatory blood pressure recordings might be required in some cases if we want to rule out white coat hypertension. Preconception management of chronic hypertension is also important, because those patients who are trying to conceive and those patients who are already taking medicines, we need to switch them to other drugs because of the teratogenic effect of this drug. So we should stop all SE inhibitors, we should stop all ARBs, ARNIs and MRS, mineralocorticoid receptor antagonists. And we should switch them to long-acting oral formulation like labetalol or nifedipine, and even switch from the amlodipine to nifedipine and other beta blockers to labetalol. Although data against the use of the thiazide diuretics is not robust, but still we are usually avoiding them if we this thiazide diuretics in pregnancy. So if we discuss that, we are discussing hypertension. So which are the safe medicines for treating hypertension in pregnancy? These are labetalol, methyldopa, metoprolol and nifedipine. So we'll be using these 4 drugs for the management of hypertension. Initiation of therapy in pregnancy. Chronic non-severe hypertension. It is recommended to start with oral antihypertensive agent in chronic non-severe hypertension. It is preferred agents are labetalol, nifedipine and methyldopa. And secondary analysis of the data. So from the CHEP trial, it showed that there was no difference in the maternal and fetal outcome between labetalol and nifedipine. So we can give labetalol, nifedipine or even methyldopa. Pregnancy-related non-severe hypertension, when the systolic blood pressure is between 150 to 160 and diastolic blood pressure is between 100 to 109, it is recommended to start oral medication if delivery is not expected between in the next 24 hours. Then we should start an oral antihypertensive therapy, and it is proven positive outcomes with respect to maternal postpartum health and stillbirth rates and intrapartum complications. So we should start oral therapy if there is blood pressure between 150 to 160 and 100 to 109. In the cases where systolic blood pressure is between 140 to 149 and diastolic blood pressure is between 90 to 99 millimeter of mercury, it is recommended to treat any new onset hypertension after 20th week of gestation if delivery is not expected within next 24 hours to 7 days. And borderline pressures should be treated individualistically, and Some physicians, they prefer to initiate therapy in case of any warning signs of preeclampsia like headache. Such patients have to be closely monitored, and home blood pressure monitoring and charting will be helpful in these cases. Now, when the blood pressure is between 130 to 140 and blood pressure is between 80 to 90, so these are in this borderline range, two groups of the patients should be treated with pressures in this range. These two groups are, one group is antepartum adolescents. They should be aggressively managed if their blood pressure comes between 130 to 140 and diastolic blood pressure is between 80 to 90. And other group is where you know that preconception blood pressure was already between 90 to 100 millimeter of mercury. So in those cases, if you find that blood pressure has now rose up to 130 millimeter of mercury after 20th week of gestation, then we should start medicines in these two groups. Drugs doses for oral treatment of hypertension in pregnancy. So first is there's a labetalol. It is safe in pregnancy. It has combined alpha and beta blocker activity. Initial dose is 100. We should start with 100 milligram twice a day, and we can increase by 100 milligram twice a day every 2 to 3 days. And usual effective dose range is 200 to 800 milligram into divided dosing, and maximum suggested total daily dose is 2,400 milligram. It is maximum suggested total daily dose, and we should not give this drug when the patient has bradycardia or has heart block, and when the patient has history of acute asthmatic attacks. So in cases of chronic obstructive lung disease or the acute bronchial asthma, and in patients with bradycardia or having heart blocks of more than first degree, in those cases we should not give this medicine, labetalol. Then comes the nifedipine, extended release nifedipine. It is a calcium channel blocker, and initial dose is 30 milligram to 600 milligram once a daily, but in some cases we can even give it twice a day, and we can increase it at the interval of 7 to 14 days, and maximum daily dose is 120 milligram. Another drug which is used for management of hypertension in pregnancy is methyl dopa. It is a centrally acting alpha agonist, and it is usually initiated with the dose of 250 milligram 2 to 3 times a day, and it is increased every 2 days if required. And also it is to be noted that this drug needs at least 2 days for its full effect. So we should at least wait for 2 days before increasing the dose of methyl dopa. And maximum daily dose for methyl dopa is 3,000 milligram, and most common side effect is sedation. And if the blood pressure is not controlled with these three medicines, methyl dopa, extended release, nifedipine, and labetalol, then only we should use hydralazine. And it should not be used as monotherapy because it causes reflex tachycardia. So it should be combined with methyl dopa or labetalol. It is peripheral vasodilator. It should begin with 100 milligram 4 times a day, and maximum dose which we should give as 100 milligram. I will advise that more than 100 milligram is known to cause drug-induced SLE. So we should be cautious while using more than 100 milligram of daily dose of hydralazine. Then comes the acute therapy of severe hypertension in pregnancy. So intravenous therapy remains the mainstay of treatment when there is severe hypertension, and the target systolic blood pressure should be 130 to 150 millimeter of mercury, and target diastolic blood pressure should be 80 to 90 millimeter of mercury. Commonly used intravenous therapy for the treatment of severe hypertension in pregnancy are IV labetalol and hydralazine. Even oral fast-acting nifedipine is recommended by American College of Gynecologists, but it is to be used very cautiously because it can cause precipitous fall in blood pressure. Even it can cause myocardial ischemia and arrhythmias. So we should be careful while using fast-acting nifedipine. For acute management of severe hypertension, IV labetalol is recommended as first line of therapy. And when there is asthma or maternal heart rate is less than 60 beats per minute, these are the absolute contraindications. And preferred heart rates are more than 110 beats per minute. We should start it as bolus 20 milligram over 2 minutes, and it should be followed by boluses of 20 to 80 milligram in 10 minutes interval. We can even start infusion at 1 to 2 milligram per minute. Effect usually starts in 5 to 10 minutes, and maximum cumulative dose for giving this IV dose is 300 milligram. So this is the first line of therapy, labetalol. Then is IV hydralazine. We should begin with 5 milligram of IV bolus and then wait for 20 minutes to see the response. And if there is no response in 20 minutes, then we can give additional boluses of 5 to 15 milligram of hydralazine. And maximum cumulative doses 20 to 30 milligram. And if there is no effect, then we should consider switching to labetalol or oral nifedipine. Even if IV nicardipine is available, then it is also useful. Oral nifedipine, it is available in both formulation. One is extended release formulation and another is the immediate acting formulation. Immediate acting formulations are usually not recommended except when there is severe hypertension, blood pressure of more than 160 by 110 millimeter of mercury. And we should be cautious while using this immediate acting nifedipine because it can cause precipitous fall in blood pressure, and then there will be reflex stimulation of maternal sympathetic system, which can lead to various other complications, like it can lead to stroke, myocardial infarctions and arrhythmias. In refractory cases of acute severe hypertension, even in those cases when they are refractory to first line of treatment, following things can be tried out as a bailout. One is IV nicardipine infusion can be tried at the dose of 5 milligram per hour to 15 milligram per hour. Even a small can be tried. It is relatively cardioselective. Its half-life is 9 minutes, and it is usually used in pregnant patients in thyroid storms. The dose which we use in these cases is 250 to 500 microgram per minute bolus, followed by 25 to 50 microgram per kg per minute infusion. IV NTG can also be tried in refractory cases, and even sometimes nitroprusside sodium infusion can be tried, but with the fear of fetal thiocyanate toxicity, we usually don't use IV nitroprusside sodium. Other non-pharmacological intervention in these cases when patients have hypertension in pregnancy. One is bed rest, which is not routinely recommended with patients with hypertensive disorders. In fact, it is detrimental to the outcome, as the limitation of the physical activities in pregnancy has been associated with worse pregnancy outcomes, especially in the patients who are having other risk factors like diabetes or gestational diabetes mellitus or obesity. And at the same time, treatment should be individualized in these cases. So, these cases with chronic hypertension, they do not benefit from activity limitation, whereas pre-eclamptic patients, they need activity limitation to maintain more stable blood pressures. And other things are that low salt diet and DASH diets are routinely recommended in these patients. Hypertension in postpartum women. blood pressure usually falls immediately postpartum within minutes. Then again it starts rising and it peaks at about 5 to 7 days postpartum, and then it settles up by the 42nd day postpartum. So at the 6-week postpartum, it usually settles. But when there is higher blood pressure, even after the 6-week postpartum, it is called as chronic hypertension. And even a small fraction of the women who develop hypertension in the postpartum state, they are those with the postpartum eclampsia. Transient hypertension sometimes may be due to large volume of the IV fluid, and rare causes of hypertension in the postpartum period is primary hyperaldosteronism, which is usually masked by progesterone during the pregnancy. So when there is no progesterone in postpartum, means less progesterone in the postpartum period, it can unmask primary hyperaldosteronism. So it should be kept in mind when patient develops hypertension in postpartum period. Postpartum hypertension in women developing hypertension de novo in pregnancy. It is seen in women with first pregnancy above the age of 35 to 40 years. And women with preeclampsia, they are more prone to develop sustained hypertension. There are several studies also, in one study in Netherlands, in 200, it was done in 200 patients with preeclampsia. And those cases also received ambulatory blood pressure monitoring at 12 months postpartum. And it was found that 42% of the patient had sustained hypertension, either masked or overt. However, routinely we don't use ABPM in all postpartum female because it is not economically feasible. But we should be watchful in those cases, like they are susceptible to develop hypertension in postpartum period also. This is the trial, CHEP trial. This trial was done in patients with hypertension, and during the pregnancy, it was open-label, multi-center randomized control trial where 2,408 patients were enrolled. And there were two groups. One group was that where they managed blood pressure intensively, and they kept the blood pressure to less than 140 by 90 millimeter of mercury by giving drugs. And another group was where they managed the blood pressure to less than not that aggressive management of blood pressure to less than 160 to 108 millimeter of mercury. So it was active versus standard management, and inclusion criteria were pregnant women with chronic or newly diagnosed hypertension before 23 weeks of gestation. Primary outcome was composite of preeclampsia with severe features, medically indicated preterm birth at less than 35 weeks, and placental abruption, and fetal or neonatal death. So with active management of blood pressure during pregnancy, there was 18% risk reduction, and number needed to treat to prevent at least one primary outcome was 14.7. So in conclusion, we can say that active lowering of blood pressure during pregnancy to less than 140 by 90 millimeter of mercury is associated with overall better outcomes with respect to maternal and fetal health. So we should manage these cases actively. All the cases of hypertension in pregnancy should be managed very actively, and this active management is ultimately associated with better outcomes in terms of better maternal and fetal health. Thank you.